I'm going to pull it up there. Just give me a sec. Sometimes my iPad just doesn't want to. There we go. Let me make sure I actually have my sound on this. I do. Awesome. Alrighty, so we're just going chapters 13 and 14, and then going over some questions with the most missed topics. I think there's like 3 or 4 for chapter 13 and only 1, I think, for chapter 14, so this shouldn't be too painful. First things first, chapter 13, these were the major concepts that we covered for chapter 13. Chapter 13 involved infection and disease processes. Understanding basically major concepts of what infection is and the disease process and how it develops. So infection basically refers to any time that an organism is getting into your body and multiplying. If it has the potential to cause disease, then we would call it a pathogen. And pathology is a term referring to the damage, the disease, what we see as a negative aspect of the infection. Disease is defined as deviation from health. This could be any deviation from health. So even cancer, diabetes, and things like that are still disease. But infectious disease is disease caused by our pathogens, right? And so understanding the difference now, we're breaking down the terms a little bit more in this chapter. Pathogens can be caused by microbes that are already part of your biome or caused by microbes that are coming from outside of your body that weren't there already. Resident and microbial antagonism. Resident is talking about like our resident microbes. This would be our microbiome. And so this is really just referring about any of the bacteria that are part of your normal flora of your body, whether that's the bacteria on your skin or the bacteria in your gut, the bacteria in your throat, in your sinuses, in your lungs, whatever it is. And most of the areas of our body do have some aspect of microbiome, primarily bacterial. But your microbiome can consist of bacteria, viruses, protozoa, or fungi. Fungi more commonly we'll be thinking of the yeasts there. And so that's something to remember as well. The only organisms that we never see as part of your microbiome will be the helminths. Microbial antagonism. This is that concept that I talk about all the time with like the stadium seats and stuff like that. So your normal microbiome takes up any potential stadium seats in your body, preventing seats from being open for pathogens. Your microbiome also can produce waste products that can basically deter pathogens. They can produce antibiotics that they make on their own. They can produce toxic, exoenzymes and things like that that can be harmful to any incoming bacteria. Anything that allows your normal microbiome to prevent pathogens from taking hold is microbial antagonism. True pathogens are organisms that cause disease even in healthy people. This is COVID. This is tuberculosis. These are things we don't see those things as part of your normal biome and then deviating somewhere else. Like with, when we talk about you getting a UTI, if you get a UTI caused by E. coli, the E. coli that caused that UTI is not a true pathogen. It's an opportunistic pathogen. It's a bacteria that is common in your gut, but has moved to somewhere it doesn't belong, but it's not a true pathogen. It's not always a pathogen. But whenever these true pathogens get into your body, they're always just pathogens. And so that's our definition there. Opportunistic pathogens cause disease when your defenses are compromised, whenever your shift in your biome has changed, like what we've talked about with C. diff. C. diff can be part of your actual biome. It's not necessarily a true pathogen. So whenever we start seeing that happening, that's an organism that we would consider to be an opportunistic pathogen. It existed in your colon, but now has overgrown through a process that we call superinfection, which is a Unit 3 concept. But anyways, that's the difference between true pathogens and opportunistic pathogens. COVID is always a true pathogen. You know, E. coli can be an opportunistic pathogen. Virulence is a measure of the degree of pathogenicity. Well, we already talked about pathogenicity and pathology being the damage that's done, right? So this is the degree of basically how the disease is presented, the degree of disease. Don't overthink it, okay? Virulence is talking about the degree of damage that's going to be done. That's what virulence is. So a virulence factor is anything that a microbe has that allows it to cause disease or damage. So anything that it has. So if it has a capsule, does that help with it causing infection and causing disease? Yeah. So having a capsule, that's a virulence factor. The ability to be antibiotic resistant, if it has genes for that, that's a virulence factor. If it has flagella and it's able to be motile, that's a virulence factor. So any aspect of that microbe that helps it establish infection and cause disease in favor of the pathogen, that's a virulence factor. These are traits of these organisms. This is a concept that's really pretty important whenever we're making our disease presentations, if anybody started working on those. This is going to ask you for virulence factors of your organism. So if you pick a bacteria that has flagella, you better be talking about that flagella and how it helps with infection, the infection process and the disease process. All right. Let me mute my phone or watch, whatever this is. All right. Portal. So let's get into the actual infection process, which is where this part's starting, infection process. We'll start with our portal of entry. How does it get in? You're either exogenous, you started outside the body and you got in, or you're endogenous. You started in the body and now you're overgrowing or something like that, like what we see with C. diff. C. diff is an endogenous infection. You already had C. diff in your colon in small numbers and now it's just overgrowing. That's an endogenous infection. You got a UTI because some of your poop bacteria got into your urethra. That is an endogenous infection. It came from in your own body. You get COVID, that's an exogenous, stuff like that. So thinking about that way. In our steps, in our process of infection, we have to find our portal of entry, which is how we get in. The next step, this would be our first step. The next step is your attaching and adhesion step. This is basically sticking to whatever surface or attaching to whatever receptor, whatever you need to, so you can actually start your growth and multiplication process. So this is either going to be helped with things like fimbriae, which were attachment molecules in bacteria. It could be the capsules themselves, which are the sticky coatings on our bacteria, or it could be the spike proteins on viruses, which act as keys into the doors on our cell surfaces. This is where we reintroduce that concept of quorum sensing in biofilms, which we've talked about it previously. We've talked about it in chapter 4. We talked about it in chapter, I believe, 25 or 9, one of those. And now we're talking about it again in chapter 13. Quorum sensing is the ability of bacteria and other microbes that are part of a biofilm, which is a sticky layer with many different species of microbes in it, basically being able to communicate with each other through waste products, through protein signaling molecules that they make that helps the bacteria in that environment just know how healthy their nearby environment is. So quorum sensing is that ability to communicate with those signaling molecules between the organisms in the biofilm, and it lets them know how healthy overall that biofilm is and whether they want to stay in it or not. This happens in the plaque in your teeth, just to remind you guys of that again, because we love being reminded of that. All right, so next is surviving the host defenses. That would be number 3. We already know that the number 1 defense that our body has against any pathogen is going to be phagocytosis, our white blood cells in general eating up bad guys. So in order to survive that, you have to have some sort of anti-phagocytic factor. And all of these will be virulence factors. So this is either being able to, there's a few ways we can look at it. You can either evade being eaten, evade the phagocytosis altogether. This includes our capsules. This could be preventing that phagosome, which is what you get eaten up into. So you get eaten by the white blood cell into the phagosome, but prevent it from merging with the lysosome. Or it could just be something that allows you to survive that process. So these are all possibilities that microbes could potentially have. And now we're going to get to the part where we're going to infect and cause disease. So this is like our fourth step. So now we're actually in the process of causing disease. Anything involved in the causing disease would be more virulence factors. So this includes our toxins, which can be exo or endotoxins. Just a reminder, if you are an endotoxin, there's only one and only endotoxin, which is lipopolysaccharide. I'll write it out one more time for you guys. Also known as LPS, on the surface of gram negatives, outer membranes. Always, that's what endotoxin is. Anytime you hear endotoxin, that's always what it is. So endotoxin, a toxin that is part of the actual bacterial structure, which is why it's endo, is found on all gram negatives in their outer membrane. That's what endotoxin is, period. Every time we hear it, that's what that is, okay? So exotoxins are toxins that are produced by the bacteria. These could be, some of them can be exoenzymes. So some exoenzymes act as toxins. Exoenzymes are what they sound like, just like we learned about enzymes in chapter 10. And exoenzymes are just enzymes that are secreted by the bacteria. This includes things like collagenase, hyaluronic acid enzymes that break down hyaluronic acid and stuff like that. So collagen and hyaluronic acid, both of them incredibly important in our extracellular matrix for keeping our cells held together and creating our tissues and keeping them as individual tissues. Many bacteria make exoenzymes that break down collagen or hyaluronic acid. Hyaluronidase is what that enzyme is called. And they break down those things that enables them to get deeper into the tissues. So those would be exoenzymes. And are those toxic to us? A toxin is anything that can cause damage or cause basically damage to our cells, generally speaking. So enzymes are generally going to cause damage to us. So they're also exotoxins. So exoenzymes are just a subset of exotoxins. So there's other exotoxins that are not going to be enzymes. So whenever we think of Clostridium botulinum making botulinum toxin, that is not an enzyme, but it blocks the release of acetylcholine. It's still a toxin. It's going to cause cell death and damage and things like that. So that's what the difference is between those kinds of toxins versus the enzymes and things like that. So remember that an enzyme, anytime we hear that word, an enzyme is a protein that acts as a catalyst for some sort of chemical reaction. When we're following infection, there's different patterns of infection that we can see. Localized infection, this is going to be like whenever you have like a boil or a pimple, it's in one spot and that's where it is. It's not spreading anywhere else. Systemic infections are going to be all over. Just one spot. Systemic is going to be all over the body. Focal is spread from one spot to another spot, like it's like the next level of local. One spot to another. So for example, you have a sinus infection, and then now that infection that's in your sinuses has migrated down into your lungs, and now you have a cough. Focal, that's a focal infection. So we've spread from one place to another area in the body, but it's not systemic. It's not all over the body yet. So it's kind of in between. Mixed infection is where you have multiple microbes involved. And then primary versus secondary is where you have initial infection that causes a different infection. Example, you have a yeast infection that you take antibiotics for. And now not antibiotics. You take you have a yeast infection. You treat the fungi that are the yeast infection, which is Candida albicans typically. So you treat the yeast, but now those stadium seats are open and now bad bacteria can overgrow. And now you can have BV as a result of having had treated your yeast infection. So that'd be a secondary infection. Would you have had BV if you didn't have the yeast infection? Probably not. And so that's the idea with the secondary infections. This is actually pretty common too when we look at viral infections. Like you have a cold, the cold, which is usually caused by a virus, right? Common cold, 200 different viruses can cause a common cold. But then the inflammation from the cold makes you get a secondary bacterial sinus infection. So it's a different infection, but if you didn't have the cold, you wouldn't have had that. So that's the idea with that. And then acute versus chronic. This is usually defined by each disease, but basically acute infections are things that are typically more severe and shorter lived, but chronic infections typically less severe, but much longer lived, and can even be lifelong. So it just depends. And these are defined on a disease by disease basis, how that would be. But acute is usually more severe. It presents more pathologically severe upfront and is usually more short-lived. The chronic, less severe, but more prolonged. Next, we get into signs versus symptoms. The way that I remember this is that if you had an actual physical stop sign, you could literally hold the sign. So that's something you can tangibly prove is there. I can't say the same thing for the word symptom. I can't. And so if I had a stop signs you can actually hold, you can actually measure. So signs are objective, whereas symptoms are subjective. So differences, obvious ones that we could talk about here. Signs are things that are measurable. So this would be things like fever, high white blood cell count. You can actually measure these things. You can actually see them. Is the patient vomiting? You can actually observe that. However, symptoms are just reported. So this would be things like pain and fatigue. I'm so tired, I just can't get out of bed. Can you actually measure that? No. Can you kind of observe it? Maybe, but like.
Would being nauseous be a symptom?
Yes, nausea would be a symptom, but if you have actual vomiting, sign. Exactly. So that's a great distinction there. All right. Syndrome is a term that refers to a disease that is defined by signs and symptoms, not by cause. Okay. So think of it this way. When we think about meningitis, well, if you guys are in the nursing program, then you are probably well aware and has been drilled into your brain a million times. There are a lot of different causes of meningitis. You're going to assume it's the worst one at face value and treat it as such until you get a proper diagnosis. But there's so many different causes of meningitis. There's so many. And they aren't just all bacterial. We have bacterial meningitis, we have viral meningitis, we have fungal meningitis, and those are the big three, right? And so, but what is meningitis? It's inflammation of the meninges. And then how do we actually define that as a disease? We just say the patient has a stiff neck, the patient has a headache, they have Budzinski's sign or something like that. They might have a fever. And so there's signs and symptoms that we define as belonging to meningitis, right? Another obvious one that we don't think about as being a syndrome, but it is the common cold. You have a sniffle, you might have a low-grade fever if you have a fever at all. You might have a scratchy throat and some drainage, and you maybe some fatigue and achiness. But that is what a common cold would be like versus the flu, which the flu is always caused by influenza. It's defined by its cause. So common cold, syndrome. Influenza, not a syndrome, right? COVID, not a syndrome. It's defined by it being caused by the SARS-CoV-2 virus. Right, so that's the difference with syndromes. So syndromes don't have to be infectious. We know with Down's syndrome, it's defined by the signs and symptoms. We know now that it's caused by trisomy 21, but it's defined by its signs and symptoms and how the patients actually are presenting with those defects. So syndrome is defined by signs and symptoms. Then we have septicemia versus bacteremia, which trips a lot of people up as well. Did you have to have bacteremia in order to have Bacterial septicemia, yes. But bacteremia, you shouldn't have any bacteria in your bloodstream at all, period. Your bloodstream is a sterile, closed environment. So there should be no microbes in it at all. So if you have any bacteria in there, let's say that you are going in to get chemotherapy and you've got a PICC line and it's like surgically installed for easy port access, right? You've got port there. And bacteria might get into the body there. But does that patient have septicemia yet? No, it's not septicemia until the bacteria are actually multiplying in the bloodstream. So the bacteria can get into the blood. That's bacteremia. But once the bacteria are actually multiplying and thriving in the bloodstream, that's septicemia. So they are different. Okay, so I want to be clear about that. That's one that gets a lot of people. All right, so that's the progression of our disease. Now we're finally at that point after we've caused the disease and we've multiplied and we've led to all these signs and symptoms and potentially developed a syndrome or whatever. Now we're ready to exit the host, ready to move on and multiply. And how do we exit the host is pretty straightforward. You're secreted, excreted, or discharged, or you're sloughed off of the skin, or the blood is transmitted to somebody else. These are pretty straightforward. I'm not going to focus on this a lot. When we have long-term infections, this can lead to chronic disease, but in some cases, you can harbor your pathogen and not have any signs or symptoms, in which case we call that latency. So this is whenever you harbor the pathogen without signs or symptoms or with, what we call subclinical. You're not worried about whatever's going on. You might be tired, a little tired, but you're not worrying about going to a doctor for it or something. So latency is whenever you're harboring that and you're not having any issues. Versus when we look at sequelae, sequelae is a term that refers to effects that you're having from the disease even after you've cleared it.
Would that be like having like a really bad cough after having COVID?
Yes. And so even like when we call it with long COVID, right? Those people that have long COVID, they usually have cleared the virus from their body, but they're still having the inflammation. They're still having the signaling in their body and stuff like that. More obvious ones, and one that I feel like is pretty typical, would be like with polio, right? If you get polio and you're paralyzed, that's a sequelae. So FDR had sequelae from having had polio. He was paralyzed from it. And that sort of stuff. So yes, having had certain diseases, even after your body has cleared them, your body still has been trained to have certain reactions to things. This can make you more susceptible to having these lasting effects, or it could just be damage that the virus did or the bacteria did that's just still lasting after the fact.
Is that lifelong usually, or is it like?
It just depends. Yeah, it just depends on the disease. So sometimes it can be lifelong, like what we have with the paralysis with polio, but sometimes you can recover from these sequelae. But anytime you have any lasting effects afterwards, that's what sequelae is referring to. The 4 phases of an infection align pretty closely with our bacterial growth curve. So we have incubation, which aligns with our lag phase. The prodromal period is associated with our first signs and symptoms. You guys know what this is too. Ever had a cold where you like the day before you start getting really sick, you start having a scratchy throat and you feel a little tired or something and you're like, I'm coming down with something. That's the prodrome. Okay, so prodromal phase or the prodrome is when you have your very first signs or symptoms. Invasion is also known as the acute phase. This is when you're at the height of the disease. And this aligns pretty well with our log phase or exponential phase of our growth curve, which we learned about in chapter 9. And we have convalescence, which is whenever the disease starts easing up and you start getting rid of the pathogen. So clearing the illness. You might clear it completely or you might not. It might become latent or whatever. But once you start lessening from that acute phase, that's the convalescence. All right. The next part's talking about like basically where diseases are coming from and how they're transmitted. reservoirs and sources and carriers. So a reservoir is a place where the pathogen exists naturally. This is where it exists naturally. The source is where this outbreak came from. So let's say bats are the reservoir for Ebola in the, Congo or something. They can have Ebola in their bloodstream and not have hemorrhagic fever. They just can have it, and it just exists in their bodies, right? So they'd be reservoirs. But if there's an outbreak in a village nearby because they hunted bushmeat, even let's say it's a bat, let's just say it's a bat, that bat was the source, not all bats, right? So all bats can be the reservoir. That one bat was the source. Carriers are people who have the disease that don't have obvious signs or symptoms. They are subclinical, but they can pass the disease on. Subclinical or completely asymptomatic, which are different things, right? So subclinical, you feel a little icky, but you're still going out and about. Asymptomatic, you don't even have any signs or symptoms. But these are people that can transmit the illness that aren't aware of it. How many times have we had the cold or the flu and we're feeling good enough to go back to work, but you're still icky? You know you're contagious, y'all know you're contagious, but you be a carrier in that situation, right? And a zoonosis, these are, I feel like speak for themselves, right? Zoo, just like a zoo. These are the illnesses that are transmitted by animals. So like rabies, for example. Even influenza, we could kind of categorize into this because a lot of times the original viruses for influenza came from birds or swine. But yeah, more common ones we would think of would be like rabies. All right, biological versus mechanical vectors. So when we think of the bird flu, the birds that we're getting the flu from, are they actually multiplying the virus in their bodies? Yes. So they are biologically infected with the virus in that case. So they are biological vectors. However, when you think of a fly landing on on an animal's poop and then landing on your food, and then you eat it and you get sick because of that, that fly was not actually infected with the poop, right? So it's a mechanical vector. So I feel like the pictures in the lecture, the lecture or in the textbook do a pretty good justice for this. Flies and cockroaches, common mechanical vectors for carrying disease, but they are not infected themselves. Sometimes mosquitoes can be one or the other. Mosquitoes can actually be infected with malaria. In fact, that's part of malaria's life cycle. Malaria actually infects the mosquito. Other times, mosquitoes can potentially drink somebody's blood and then pass on the disease to the next person without having to be infected by it. And so that would be a mechanical vector. So they can sometimes be one or the other. It just depends on the specific disease that you're talking about. The biological vectors are actually infected. Whether they have disease or not doesn't matter. But if they're actually infected and harboring that microbe and it's growing in them, then that is biological. All right, moving on to communicable, contagious, non-communicable. All right, so non-communicable can't be transmitted. If I fall and I scrape my knee and my knee gets infected, are you likely to get that disease from me? No, that's not non-communicable, right? Trying to think of other examples. I always get stuck on this one, even though I feel like there's a lot of really obvious ones. But if you get a disease and it can't be transmitted to another person, then that is non-communicable. There's a lot of them. We can think of them. We just don't think of them often because we just think like, oh, well, I scraped my knee and it's infected. Unless I rub my infected knee against your open wound, you're probably fine, right? Like it's a non-communicable disease. All right. So whereas communicable, it can be transmitted from person to person. Contagious is the next level of that. Contagious is highly communicable. Me getting sick with something that could pass to you if we had like the perfect scenario, that would be communicable, but is it contagious? So let's think of hepatitis C, for example. Hepatitis C involves direct blood transmission. So it's communicable. I can transmit it to you, but is it contagious? I wouldn't say so, right? Because me just having it and you being near me, you're not going to get it. Yeah, you'd have to actually have a true blood exposure for that to happen. Okay, so those are the differences there. Horizontal versus vertical transmission. We kind of talked about this previously, but just to remind us, horizontal is basically from parent to offspring. I mixed it up. Vertical is from parent to offspring. So I think of it as like a tree, like a family tree, how they would be stacked vertically, like the mom down to the kids. That's vertical transmission. Horizontal is from person to person. So if you are in your mother's womb and you are, when you're being born, are exposed to your mom's herpes, and you get herpes when you are born because you're exposed to your mom's herpes outbreak, that would be vertical transmission. However, if you are later on in life, you have a sexual partner, and then you transmit your herpes to your sexual partner, that's horizontal transmission. Okay. Vehicles and fomites. The fomites are a type of vehicle. They are non-living, inanimate objects that can act as a vehicle. You see guys probably all the time, and me in class, I have a hard time not touching my face or my mouth and things like this. I'm really bad about it. But let's say I have COVID right now, and I came over and looked at your microscope, and I've been coughing on my hands all day, and I hadn't washed my hands before touching your microscope or whatever. And I, diddle daddle with your focus knobs on your microscope, and then you touch the focus knobs after me, and then you touch your face, and now you've got COVID after I had COVID. That microscope would have been a fomite. Obvious ones are like keyboards, doorknobs, pens, things like that. Those are fomites. So fomites are inanimate objects that can help with the transmission of a disease, but they themselves are not infected. Okay. They're not a source of the infection, right? They're just a means of transmitting it. We also have oral fecal, speaks for itself. Organisms that can exist naturally in the water or in the soil. Vibrio is one of the ones that can exist naturally in water. We have Giardia and things like that that can just be found in the soil, in the water, anthrax, things like that. Air, pretty common method of transmission. That's usually going to be via droplet nuclei or aerosols. So whether you sneeze and the wet droplets are going somewhere, or the droplets dry in the air in these little micro formats that we call the droplet nuclei. And then those can kind of hover in the air for weeks even. Not say weeks, but more likely hours, So yeah, so that can exist in the air and still be transmissible. Some diseases, like with measles, is pretty resistant. So I can be in a room and leave and have the measles and just come into the room and breathe in the room, not touch anything. Just come into the room with measles, breathe in there, leave. You can come in 8 hours later and just breathe in there and get the measles. That is wild. That's how transmissible the measles is. That's how contagious the measles is. The most contagious disease that we've ever known in mankind is the measles, just to be clear. And people are like, yeah, right, we don't see very much of it. Why? Why do you think that is? Yeah, so we'll just leave that there. We've had this discussion before. All right, so moving on to Koch's postulates. Robert Koch came up with this idea that, hey, people are sick. So if I were to take a person, swab that person, and isolate an organism, put it into a mouse, it has the same disease, and I can re-isolate that same organism, and that's repeatable, then I found the cause of the disease. And he used this methodology. Seems really straightforward, right? But he was the guy that came up with the idea to approach that back when germ theory was brand new. And he discovered anthrax that way. So cool stuff. Moving on to chapter 14. Chapter 14 is epidemiology. This starts off with a little brief overview of the contributions of Florence Nightingale and John Snow to epidemiology. These are early epidemiology concepts before epidemiology was a thing. So Florence Nightingale is the mother of nursing. She noticed during the Crimean War that soldiers were dying of dysentery, even though they came in with like bayonet wounds and things like that. That's not going to cause dysentery. And so she realized that the soldiers had dysentery because the doctors were not washing their hands. And so she encouraged more hand washing. And so she lowered the death rate from like 30% to like 3% just by having people wash hands. So that was pretty significant. It's gross, but it is what it is. Mother of nursing. That's all they needed was a woman to tell them to be clean. And then we have John Snow. Both of these are people we need to know. John Snow was important with a cholera outbreak in London. There was people getting sick and they just kept getting sick and sick and sick. So he plotted out on a map where all the illnesses were, and it was centered around a water pump. And so he told them stop using the water pump, but people, they don't listen. So they kept using it. So he took the handle off of it, and lo and behold, no more cholera. Mm-hmm. Yeah. Lo and behold. So John Snow. So these are our basically fathers and mothers of epidemiology, our old school epidemiologists, where this concept of tracking disease and how it's spread, as opposed to treating the individual, but looking at the population, that's epidemiology. Then we come to our terms. This is mostly a terms chapter. Let's be real here. This is mostly a terms chapter. So feel free to use your flashcards and learn your terms on this one, okay? But prevalence versus incidence. Prevalence has to deal with the overall numbers of infection we'll just say total. Whereas incidence is numbers of infection in a specific time frame. Like per week or something. That's the difference, okay? So if I'm telling you about since COVID has existed, we've had 3 million people, it's been more than that, but if we say 3 million people have been infected with COVID since it's existed, that's the prevalence. But if we say in the last week, we've had 200 outbreaks of COVID, that's the incidence. Okay, so looking at specific timeframes. Morbidity is the same thing as incidence. So whenever you look at the CDC coming out with their weekly or monthly morbidity and mortality reviews, morbidity is talking about this week we've had this many outbreaks of this. Morbidity. It's morbid, but mortality is dealing with the death rates. So mortality, we're not just being morbid, we're talking about mortality. So this is death rates. All right, let's get into some more terms for our outbreaks. Let's actually start with these terms down here first, endemic and all this stuff. Endemic is something that is steady in a locale. If a person came in today with a cold, would you be surprised? No, because it's endemic here pretty much all the time. If you saw an increase in the number of people who had colds in the wintertime, would you be surprised? Probably not, because endemically, it's endemic and it's at increased numbers. That's still endemic, right? It's what you expect for that illness in that locale. Then we get into sporadic. If I get bitten by a raccoon and I get rabies, is that going to affect you? No. So that's a sporadic thing, and it's not being spread out to other people. You could also consider something sporadic if it's just this one little tiny, like a couple people were affected, but that's it. It didn't spread outside of that. You could still have more than one person involved. But once it starts spreading at larger numbers throughout the population at a rate that you do not expect, that's when you have an epidemic. So if we started having somebody travel to another country and they came here and now they're spreading Ebola, right? Well, when we had Ebola come to the United States and somebody has Ebola and then their healthcare workers get Ebola and then the people they were in contact with got Ebola, that's an epidemic. Okay, so it exceeds the prevalence of what is expected in a population. This includes new diseases. When we didn't have COVID versus we had COVID and it was spreading amongst people here in Oklahoma, that was an epidemic. Once something crosses continents, it's pandemic. All right, so now coming back up to these up here, the point source versus the common source versus the propagated. When you have an outbreak, a point source outbreak is where you can say everybody got sick at this time from this place. So if I came in here and I sneezed and 5 of you got COVID from my COVID, that was one point in time where 5 people may have gotten sick. Yes? So that's a point source. Common source So common source means we're getting it from a common source, but not at the same point. So if you know the three terms, which were point source, common source, or propagated, you should be able to figure out what each one is. So common source, it comes from a common source, whereas point source, it came at a single point. Okay. So common source, this was like our cholera outbreak with Jon Snow. People were getting sick over weeks. They didn't all contact that one water source at the same time, at one point in time. It's not a point source. It's a common source. If you go to the fair and one day during your visit to the fair, 5 people get sick visiting the hot dog stand, that would be point source. But if over the whole week of the fair being there, every day people are getting sick from that same hot dog stand, well, now it's become a common source outbreak. Next is the propagated, which just means that it's being sustained in the population. So like the cold virus, it's sustained in the human population. Cold, flu, COVID right now is a propagated epidemic. We're maintaining it in the human population. It is fluctuating, but it's still being maintained within the human population. All right. The people hate these, so we're gonna take a little time on these. Doing screening tests. So there's different kinds of tests we can do that are more effective than others, and we've kind of learned a little bit about that, and we're going to learn more about it in chapter 18, which is in unit 3. But this is introducing the concept of specificity of a test versus sensitivity, and this is going to come back up in unit 3. So specificity versus sensitivity. I always start with sensitivity first because I like to compare it to, if you're a really sensitive person, even the littlest little thing can trigger you. I'm not saying it's bad or good. I'm just saying if you're really sensitive, even the littlest thing might trigger you, right? Same thing with sensitive tests. Sensitive tests should be positive, even if only a small amount of the pathogen is there. So the more sensitive you are, the less likely you are to be calling something negative when it's actually positive. So sensitivity is a measure of making basically false negatives less likely. And a false negative is saying that something is negative when it's actually positive. So your COVID tests, let's look at this, right? Your COVID home test versus the PCR test. Which one's more sensitive? The PCR. And I can say that and you guys would know that without me having to confuse you with these definitions, right? Why is that? Because the PCR can detect less virus. Think of it that way. PCR is more sensitive because the PCR detects even even one virus it can detect. But your home COVID test might not be as sensitive. So it's more likely to tell you you're negative when you're actually positive. So that's sensitivity. Okay? Specificity. Let's talk about that. It's more specific to that pathogen. So if you have the flu and your COVID test pops positive for COVID, then that COVID test was not very specific. And you'd be calling it positive, even though it's actually negative. You get what I'm saying? So the person might be sick with something similar, but the likelihood that you're calling it the right thing, that's specificity. So that's why I always start with sensitivity, because I feel like it's easier to understand. Specificity is specific to that illness. The more specific a test is, the more that it will say, this is the flu, when it actually is the flu. Pretty specific, yes. So a lot of the tests that we're using in diagnostics are pretty specific and pretty sensitive. The home tests are less sensitive, right? We can also have drug tests. We look at drug tests, right? Sometimes you could be taking like amitriptyline, which is like a psychiatric drug, but pop positive for, I don't know, methamphetamine. But are you taking methamphetamine? No, right? So that's the specificity where that's gone wrong. Make sense? Mm-hmm. Okay. So, yeah, so that's the difference. You want your tests to be both of these, right? You want them to be specific and sensitive. And when we talk about measuring these guys, if I say that I use a test where we have 100 people who have the flu and were confirmed later to have the flu, but when they took their home tests, only 97 of them tested positive, then that is a measure of sensitivity. Okay. Make sense? Okay. If I said we're doing testing where people are using home tests, we had 100 patients. 100 of them tested positive for COVID, but it turns out that 5 of them actually had the flu, not COVID. Then that's a specificity measure. Okay. All right. Now that we broke that down, because that gets a lot of people sometimes. All right. These studies, cross-sectional, you're literally just taking a cross-section at one point in time. This is the defining feature of it. Cross-sectional is at one point in time, and you're taking data at one point in time. So everybody ends up being sick, and on that day, you go out and you collect data from all the sick people. What disease do you have? And what were you exposed to? Or whatever, at that specific point in time. Versus case control. You are specifically looking at people who have the disease versus people that don't, and trying to find the difference between them. This is probably the most commonly, this was one that makes most sense to people, and it's in the name. Cases that have the illness versus control groups that don't have the illness. So you went to the fair. We get all the people that went to the fair that day. You got diarrhea. You didn't. What food place did you eat at? What food place did you eat at? And so on and so forth, and try to find the differences that way. The cases versus the control groups, but not at a specific point in time, just all the cases versus all the control groups, okay? And then the last one is going to be the cohort study. A cohort study is a long-term study where you would take people that, this is the most easy one for people to understand. Let's take people who are non-smokers and people who are smokers and follow them over 20 years. How many of the smokers got lung cancer and how many of the non-smokers got lung cancer? Or we could say, we'll get a group of 100 people. We'll do a genetic tests on them, and we'll have 100 people that test for the MTHFR mutation. If you know this, the mother effer gene. It's a gene, this is an important gene, but it has to do with folate and methylation of folate, okay? Methylation of folate gene. If you have the mutation, there's a reason I'm bringing this up, I promise. If you have the mutation versus you don't, is a high indicator of getting breast cancer. So follow people that have the mutation versus people that don't over 10 years and see if they get breast cancer. That's a cohort study. Okay, so it's like looking over time.
It's similar to like longitudinal studies where like one person is given a drug every day for like 10 years. And then
Yeah.
there are like remain test subjects.
It's similar. So that is a case, and that's going to have a control. So they both kind of have control groups. But yes, so those are drug studies are very similar to these, but these are actually looking at disease progression, right? And so that's not necessarily looking at like disease progression, but maybe treating the disease, but it's a similar concept. Yes, so it's similar to a longitudinal study, but different in that you don't have as much control over the variables. You know what I mean? You're more or less just observing.
Disease progresses.
Yes, it's more observing. It's a good comparison though. Okay. Hospital-associated infections. Being aware of universal precautions and infection control officers. I'm not going to go over that too much, but you usually at every single hospital you have an infection control officer, and they're the ones that are responsible for making the rules of you have to wear gloves or you have to wash your hands after leaving the patient's rooms, and those rules and procedures that people are supposed to be following that are in place for a reason. That's your infection control officer that's making sure that that hospital is keeping up with standards for FDA and things like that, making sure that we're in regulation with that stuff. And we'll talk more about hospital-associated infections in later chapters, though. Moving on to R-naught, spread of disease, basically. Two important predictor numbers are going to be R-naught and the case fatality rate, or CFR. R-naught is, or R sub zero is how it's usually written. It's hard for me to do the subscripts on this, but it's R sub zero, also known as R-naught. This is a measure of how many people you will infect if you have the illness on average. So with COVID, for example, if you have COVID, the average right now is 5, I believe. It might have gone down since then because we've had more precautions and awareness of it. So 4 or 5 people. If you have COVID, if you're infected, and you have COVID, you are likely to infect 4 or 5 other people. That's the R naught. The case fatality rate is a measure of if you have the disease and we don't treat you, the likelihood you're going to die. So this is completely irrespective of vaccination and treatment, is the case fatality rate. So if you have HIV and I don't treat you, what's the case fatality rate? 100%. If you have HIV and I don't treat you, you will 100% die. So the case fatality rate is a measure of the likelihood that you'll die if we don't treat you. HIV and rabies are the highest, above Ebola even. Ebola only maxes at 90 at its worst. So rabies and HIV are the worst ones. There are a case fatality rate of 100. And so I would argue rabies is the worst because HIV is treatable. Not curable, but treatable, right? So yeah, you can lead a normal life with HIV. All right, so moving on, herd immunity. This is the concept of the number of people that have to be vaccinated for a disease in order to prevent it spreading to other people in the population. The more contagious, the more communicable a disease is, the more people have to be vaccinated to prevent spread. So for measles, we're looking at a 97% vaccination rate. 97% of the population of humans would have to be vaccinated for measles in order to prevent it to spread to the people who cannot be vaccinated. What people can't be vaccinated, I am not saying choose to not be vaccinated. I'm saying can't be. So what people can't be vaccinated, babies that are brand new, that haven't developed their own immune systems, usually younger than a year, 6 months to a year is when you start developing your own immune system. Most people bring their kid home from the protection of a hospital before 6 months. So, you come home with your baby 2 days after it's born, 1 day after it's born, and you got 6 months before your baby has its own ability to make its own immune system. So that baby can't be vaccinated. What if that baby's on formula and it's also not getting protection from the mother's colostrum in her breast milk? So that baby's highly susceptible to getting infections. So that baby can't be vaccinated, newborn babies. And then the elderly whose immune systems are not healthy and their protections has died off over time can't get vaccinated. So 97% of all humans would have to be vaccinated to actually eradicate measles. So that's what herd immunity is.
Is that why people bring like really young babies into the ER, even if they have the slightest cough, because
It could be anything, and that baby has no immune system. Yep. And they're going to have a much harder time recovering from that. Luckily, we have a lot of medications for the more common stuff, right? But the less common stuff or things that like RSV is difficult, right? So RSV can turn pretty severe pretty quickly in little tiny babies. We do have antivirals for RSV now, but you want to get that treated as soon as possible. And that's the highest risk one, probably. That's the most common. But then we also have whooping cough, which is actually pretty common among elderly people who they'll get it and it'll be a cough for them. But for little babies, it is like devastating. It is, yes, it is devastating. So, and that's something we have vaccines for. But people that are older, maybe not elderly, but like people that haven't kept up with their vaccines that are older can get less severe symptoms, but the babies will be very much more severe. So that's what herd immunity is. That's actually what has eradicated smallpox from the planet, is that we had enough people vaccinated that we were able to overcome the R naught associated with smallpox, even though that was a fairly contagious disease. All right, anyways, with COVID vaccine development, we talked a little bit about how COVID vaccination works. We introduced the mRNA and it gets translated, but the mRNA doesn't stay around in your body. It can't be turned into DNA, so it eventually gets degraded and broken down. But it's enough for your body to see it as foreign and develop an immune response to it and then give you memory, which we'll learn more about in Unit 3, how that memory stuff works. But side effects with COVID. It was a vaccine that came out very quickly. There was some studies done as far as risks and things like that. It was actually in phase 2 clinical trials, and it was going well. So we pushed it into phase 3 before we were done with phase 2, but we still finished phase 2. We didn't go against the rules or anything. We still finished phase 2 and everything was fine. So that's something that a lot of people get confused about as well. They're like, oh, they didn't actually finish phase 2. We finished it. We just started phase 3 before we finished it. So that's just a matter of who we're testing and how. So like a controlled group of people versus like phase 3 is large groups now, and like spreading it out to lots of people and then studying the effects over larger groups of people, as opposed to like controlled pick and choose is more phase 2. Phase 1 is like animal testing and stuff like that. So anyway, so there are government resources available where for people who got the COVID vaccines can report side effects and potentially even get compensation. And there's links available for that on the lecture slides, whatever. And then the discussion of emerging versus re-emerging diseases and neglected parasitic infections. An emerging disease is something that's new to our population. We could even say that like HIV is an example of this. We've only had it since the 80s. Versus a re-emerging disease like tuberculosis, where we had tuberculosis, it was very, very severe outbreak in, like the 1800s and before that. But then it started to die out. But then with the resurgence of HIV, we've had an increase of tuberculosis, an increase of more urban, close living situations. We have an increase of tuberculosis with that. So that's a re-emerging disease. And then we have neglected parasitic infections. Most of these infections are much more common in third world countries where hygiene practices aren't as well adapted as they are in what we consider developed countries. So most of those neglected parasitic infections, they're neglected because there's not money in them for pharmaceutical companies to treat them and study them and things like that. So that's why they're neglected. But we do have parasitic infections here in the United States, and here are some of them. Toxoplasmosis. Toxoplasma gondii is basically something that is transmitted by cat feces. It's maintained, our reservoir is the feline population. It's not super severe in otherwise healthy people, but can cause stillbirth and miscarriage in about 1/3 of pregnancy cases. Chagas disease is a disease transmitted by the kissing bug. We do have that here in Oklahoma. It is a blood disease caused by protozoa. We have neurocysticercosis, which is when tapeworms get into your brain. And we have trichomonas, obviously, the most common sexually transmitted infection caused by protozoa as well. So no, I mean, just be aware of them for now. Just be aware that they are parasitic infections. We will get into the details of the diseases much later, but you don't need to know the details for them now. All right. Yeah, that'll be chapter 23, I believe. All right. Now let's do some questions. As per usual, we have a little bit more breakdown in these previous slides that I'm not going to go over right now because I kind of just did that. But being aware of the difference between true pathogens and opportunistic pathogens, and then being aware of what a virulence factor is. And virulence factor is anything that can help that organism survive better. So which of the following is a characteristic of a true pathogen? And a true pathogen, let's write it up here again. You know how I like to do. They cause disease even in healthy people. It's just what they do. So COVID, flu, tuberculosis, they cause disease even if you're healthy. So which of the following is a characteristic of a true pathogen? Do they cause disease only in people with weakened immune systems? Nope. Even in people with healthy ones, they will cause disease. Do they require high infectious dose to cause disease? They actually typically don't. They can even have one COVID virus gets into your body and you can get COVID. So don't require a high dose of them. That's not common. Do they possess specific virulence factors that enable them to overcome host defenses? They must. That's why they're going to be successful, right? Are they harmless and only cause disease in unhealthy people? No, no, no. So C is our answer here. In patients with a robust immune system, so otherwise healthy, which of the following organisms would be classified as a true pathogen due to its ability to cause disease independently of the host's immune status? Pseudomonas aeruginosa, which is more commonly an opportunistic pathogen. Pseudomonas infections are not uncommon, right? But Pseudomonas bacteria is pretty much everywhere. You put it in the right circumstances and it'll cause infection. Pseudomonas, very common cause of nail infections. You get your nails done at the salon and you get fake nails put on. That bacteria gets stuck under there in an environment where it's protected from things and your immune system can't get to your nail bed that well. So it leads to that greenish discoloration in the nails. Pseudomonas aeruginosa is pretty common for that, but it's an opportunistic pathogen. It doesn't always cause disease all the time. It can exist probably right now. I probably contacted it several times today. It's freaking everywhere. Candida albicans. It's a very common part of your microbiome. Is it always causing disease? Nope. So it's not A or B. Mycobacterium tuberculosis causes tuberculosis. I mean, we know that's what it's associated with. You're not going to get it unless you have tuberculosis, right? And then the last one is Aspergillus fumigatus. This is also an opportunistic pathogen. You can get sinus infections with Aspergillus, but is that common? No, it's going to be a particular situation, particular person, particular environment, that sort of stuff. All right. Next is more specific with our virulence factors. Just to remind us, a virulence factor is anything that helps an organism succeed in causing infection and disease. Helps pathogen cause infection and disease. All right, which of the following best describes a virulence factor? A substance produced by a pathogen that helps it adhere to host tissues. That might help. A type of immune cell that helps the host defend against pathogens? Nope. A general measure of the number of pathogens required to cause disease? This one can get tricky if we want to get really specific, but generally speaking, no, not that. Generally speaking, not this. This is not our best answer. A method used by the host to clear pathogens from the body. A virulence factor is something that helps the pathogen survive better. And so if it helps it adhere to the host tissues, that would help it survive better. So A is our answer. In a patient with severe infection caused by Clostridium tetani, which virulence factor is primarily responsible for the disease symptoms, such as muscle spasms and rigidity? So now we're looking for something that helps cause the disease, which is our virulence factor, specifically associated with the muscle spasms and the rigidity. So is the fact that it can undergo anaerobic respiration what causes the rigidity? Probably not. Probably not. So we're going to put a tick next to it because probably not. Is it the fact that it undergoes DNA replication? Y'all, all cells undergo DNA replication. This is not going to be the thing that's leading to muscle spasms and rigidity. So this isn't special to tetani. Is it the tetanospasmin toxin? I mean, that's a giveaway. Is it the co-transcriptional translation? So bacteria can do this. They can translate while they're transcribing. But is that what is our virulence factor that leads to this? Right. So C is our best answer here. Right, next is our endotoxins and exotoxins. Remember that our endotoxin is just LPS, lipopolysaccharide, on the gram-negative outer membrane. Exotoxins, these are just molecules secreted out by a pathogen that cause damage to the host. The host tissues. Okay, so we've got our little cheat reference here. Hopefully this will be enough. Which of the following statements accurately distinguishes endotoxins from exotoxins? So we're looking for it being part of a gram-negative versus being something secreted by a pathogen. Endotoxins are proteins secreted by bacteria? No. Endotoxins are part of the bacteria. Endotoxins are released only upon bacterial cell lysis. So this is suggesting an endotoxin is part of a bacteria that's only going to get released when the bacteria is broken apart. So this is along the lines of thinking. While exotoxins are actively secreted. So this is where I'm leaning is B so far. Exotoxins are heat stable while endotoxins are, I'm not going to ask you about it on the test. I'm not going to ask you about that on the test. But it's not the answer. It's the opposite. Okay, it's the opposite. Endotoxins target specific cells or processes, while exotoxins cause systemic effects. It's the opposite of this as well. We actually already know gram-negatives have LPS as endotoxin on their surface that causes a diffuse shock response. That's what endotoxin does. Exotoxins, like we learned about with botulinum toxin or tetanus toxin, those guys have very specific targets with specific outcomes. So it's not D. Our answer is B. In a patient presenting with septic shock due to gram-negative, so what is this going to mean already? You see gram-negative, think endotoxin. It's part of the gram-negative outer membrane. All right, so they have a septic shock from a gram-negative bacterial blood infection. Which type of toxin is primarily responsible for the symptoms and how does it affect the host? Is it exotoxin that's directly damaging specific host tissues? Probably not. It's probably endotoxin, but now we got to choose between the two endotoxin choices. Does endotoxin trigger a systemic inflammatory response and release of cytokines? A cytokine is just a signal molecule in your cells. Signals for inflammation. Or is endotoxin directly interfering with host cellular metabolism? No, it's this general systemic inflammation. B. All right, the next one is syndromes and signs and symptoms. So we'll put our little cheat up here. A syndrome is a disease defined by certain signs and symptoms, not its cause. Whereas a sign is measurable, also known as objective. Objective is probably how normal people would say it, but I always enunciate it. Symptom, subjective, just reported. All right, so what defines a syndrome in medical terms? Is a syndrome a single symptom that indicates a specific disease, usually a set of signs and symptoms? Is it a combination of signs and symptoms? Yes, it is this, that occur together and are characteristic of a particular condition? Probably B. A genetic mutation that causes a rare disorder or a diagnostic test result? No, it's just going to be defined by its signs and symptoms, not the test result thing, not the fact that you have a genetic mutation. It's defined by the signs and symptoms. In a patient presenting with a combination of symptoms such as photophobia, headache, stiff neck, and fever, sound familiar? It should, because this is meningitis, okay? Which syndrome might these symptoms collectively indicate? Meningitis. I mean, I just said it earlier, but this I don't expect you to necessarily be aware of the specific syndromes just yet. We'll definitely get into some of the more specifics of it later on, but this is just allowing us to associate meningitis as being a syndrome. All right. All right, chapter 14, we covered our case control, cohort, and cross-sectional. Now we're going to apply those. So I'm going to put a little, my nose is so itchy. I'm going to keep rubbing it. I apologize, but it's like it itches because of my nose ring. And so I keep thinking if I push it a different way, it won't itch, but this lies. Okay, so let's write down our little cheat sheet for these. We have case control. We have cross-sectional. I'm trying to already define it and get ahead of myself. Or we have cohort. Okay, so case control, where you're looking at people who have the disease, the have versus the have not. In cross-sectional, we are looking at a certain point in time. And then asking, do these people at this point in time have the disease or not? And then, so I just say, look at a point in time, ask questions to the group of people in that point in time. And then cohort is looking at over a long period of time. Long-term observance. Okay, first question. Which type of epidemiological study involves following a group of individuals over time to observe the development of outcomes based on their exposure status? This is our cohort study. Next question. A researcher is investigating the association between smoking and the development of lung cancer, example that I just gave earlier. So if we're looking at whether smokers are more likely to develop lung cancer compared to non-smokers, and we're just following them over 10 years, what study is that? Just like we just said, cohort study. All right, that is it for chapters 13 and 14. Do you guys have any questions for me? All right, you guys know when you're studying for Unit 2, email me if you do get any questions. And I'll have this posted tonight along with the AI summary for it. And at 8 p.m., we will have our review session on Kahoot. Hope to see you guys then. Thanks for sticking around. All right.